Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 64th Virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I am a personal trainer and the Adult Program Coordinator at the NSYMCA in Northbrook, Illinois. This evening's presentation, entitled Common Hand Problems and Treatment Options, is being recorded so that you will be able to revisit it again. Please feel free to tell your family and friends about it so that they too can view it once it is posted on the IBJI and NSYMCA websites. Day to day, we use our hands constantly, completing tasks like driving, typing, working, playing, and even eating, often without thinking of how essential they are to everything we do. But throw in an injury to the hand, or arthritis of the thumb or fingers, or carpal tunnel syndrome, or tennis elbow, or any other pain in our hands, wrists, or forearms, and suddenly their importance hits front and center. Tonight, Peter Hoepfner, MD, will teach us about the most common hand and upper extremity problems, including fractures, tendon injuries, nerve issues, overuse conditions, arthritis, and wrist issues. In addition, Dr. Hoepfner will address concerns like lumps and bumps that may seem minor but shouldn't be ignored, and what to do about them. Dr. Hoepfner is dual board certified in orthopedic surgery and hand and upper extremity surgery with fellowship training in hand and upper extremity microvascular surgery. He is also board certified in the evaluation of disability and impairment and is known to provide highly respected opinions when performing independent medical evaluations in the medical legal community. As an expert in open and arthroscopic surgery, Dr. Hoepfner specializes in both carpal tunnel and cubital tunnel release, sports and workplace injuries, fracture care, dislocations, arthritis, tennis elbow, and orthopedic trauma to the hand, wrist, elbow, humerus, or shoulder. Dr. Hoepfner also brings specialized experience in complex surgical elbow and wrist reconstruction, particularly for patients with rheumatoid arthritis, helping many patients with difficult cases regain independence and improve their quality of life. He performs all of his own surgeries and is one of the few surgeons in the Chicagoland area who performs total wrist replacements. In specific cases, Dr. Hoepfner offers injections with platelet-rich plasma to stimulate tissue healing. With a focus on restoring function and eliminating pain, utilizing the newest, least invasive method, easy for me to say, least invasive methods possible, Dr. Hoepfner is often called upon by other orthopedic surgeons when their patients have particularly complicated upper extremity cases. In addition, Dr. Hoepfner has published numerous articles in leading medical journals and serves as an instructor of hand injuries for the National Hand Surgery Organization, where he teaches the most current techniques in treating complex wrist, elbow, and shoulder injuries. Dr. Hoepfner was on the Northwestern University Medical School faculty and truly enjoyed educating residents and medical students. He also holds a patent for an implant in thumb arthritis. In addition to formally educating future doctors, Dr. Hoepfner enjoys educating his patients so that they understand what they are faced with, what the diagnosis is, and the various treatment options available to them. Dr. Hoepfner has been in practice since 1998, and he strongly believes in incorporating his patients into the decision-making process surrounding their individual care. Though he often faces cases where there is a traumatic injury and the course of action is fairly clear, he also sees patients whose situations aren't trauma-based, and he enjoys collaborating with them to discuss what's necessary and together deciding what course of action will lead to the best possible outcome for each. During Dr. Hoepfner's presentation this evening, you might find that you have questions for him, which he will be happy to address at the end of the program. Simply type your questions into the question section on your screen, and I will receive them and relay them to Dr. Hoepfner immediately following his presentation. I do ask that you please keep your questions general, as he will not be able to address individual concerns without individual consultation. If you do have self-specific questions, please contact Dr. Hoepfner via one of the options that will be listed on the slide shown during the Q&A portion of his program at the end of his presentation. One last thing before I return the evening over to Dr. Hoepfner. Please mark your calendar for our next IBJI and YMCA Education Series program on Wednesday, July 16th at 7 p.m. Dr. Paul Goodman will discuss myths and misconceptions around bunions. Thank you again for joining us tonight, and thank you, Dr. Peter Hoepfner, for your time and effort in putting together this program to educate us about common hand problems and treatment options. Dr. Hoepfner, please take it from here.
Okay. Well, thank you to everybody, at IBJI that was in the background and helping set this session up, as well as with Karen. Once again, I greatly appreciate it. I could probably talk for hours on this topic, but I've tried to distill some of those major things that I see routinely as I see patients in my office during the week, and I thought I'd share some of those things with you, and then hopefully answer any questions you may have at the end. I am a fellowship trained hand surgeon, so really 99% of the orthopedic problems that I treat are essentially from the elbow to the fingertip, and it involves various issues such as traumas, but also repetitive use in problems, hand and wrist arthritis, tendonitis issues, and once again, I'll talk a bit about elbow problems. I also have a few slides dedicated to lumps and bumps, which are a pretty common problem that people will ask me, is this something that's normal? Is it not normal? And what should we do about it? So you can see my outline there. Let's move on to basic anatomy. This truthfully is one of the reasons why I chose to go into hand surgery. The anatomy of the hand is truthfully very complex, and yet such an elegant combination of the various anatomic structures. Obviously, we have bones, tendons, ligaments, arteries, veins, and nerves that are all surrounding the bones that help make this magical anatomy function. And for us to be able to put our arm in space and pinch things and feel things is truly just an amazing wonder. And it's a joy for me to treat people with problems that involve their hand and arm and hopefully return them back to those things that they love to do. So let's go into the bony structures. As an orthopedist, it's truly one of the foundation. It is the skeleton, the scaffolding of all of the soft tissue on our body. Bones, we typically are dealing with fractures, and as an orthopedist, we'll need to look at that critically and decide, is the fracture a stable or unstable fracture? There are various factors that go into that, but one could have just a simple crack through a bone where there's really no surrounding soft tissue injury, or that bone could be severely displaced, which ultimately can have a worse outcome for patients and would likely require surgery for the orthopedic doctor to put the bones back in their correct position. One little tip, I'm often asked, doctor, is this broken or is it fractured? And that means exactly the same thing. So breaks are fractures, and you can impress your family with that once you are able to tell them about it. Now, when the bone involves a joint, we look at it even that much more with a close eye to determine if that is an acceptable alignment of the fracture, or does it require us to put it into perfect alignment? Usually when it involves the joint, we want it to line up perfectly. Otherwise, if a fracture heals and it involves the joint surface, then you're at more risk of developing arthritis. So I mentioned briefly about the complexity of the hand. Just the hand itself has 27 bones, and they just work beautifully with one another and in synchronicity, really. And if there is an injury, for instance, to a tendon, the forces across one of the joints may be different, and you'll get an issue that occurs downstream from where that tendon is usually functioning. And so it's really a critical thing for the orthopedic hand doctor to know all of the various structures, obviously the anatomy, but when knowing that, you can really kind of very logically figure out what might be injured. So anatomy involves nerves. If you look at the top schematic, you see that is really the core of the spinal cord, and these yellow structures are the nerve roots that exit from the spinal cord. Way to the right, you see that these nerve roots, I will often tell patients, these are like coaxial cables. They carry the signal, the electrical signal, from the brain through the spinal cord out to the finger. And then the signal is sent back up through that coaxial cable back to the brain. So when we touch something, if it's hot or if it's rough or bumpy, that is processed by the sensory receptors and sent back to our brain. So if the nerve is cut or injured, we could potentially lose sensation. And I'll have some examples of that type of injury here in a few moments. Nerves can also have compression on them. And that's what occurs in, for instance, carpal tunnel syndrome. If there's actually pressure on that nerve, such as, for instance, maybe something very heavy pushing on the coaxial cable and the signal is not getting through, then you will have altered sensation downstream. And that's what happens in carpal tunnel syndrome. Patients develop numbness and tingling in their hand, and it's because of pressure on that nerve. So I bring this up. Maybe this is a public service message. Please be careful when doing, when cutting avocados and removing the pit. Just use a spoon. I've seen way too many injuries where the knife slips off of the pit, and it could be the most innocuous small laceration that occurs in the hand, but patients will often have major injuries such as nerves or even tendons. And when the nerve is cut, the patient will, after this particular, for instance, an avocado injury, they'll come to my office and say, I can't feel this one side of my finger, it's completely numb. And then we can conclude that the small nerve, which is about the size of a spaghetti noodle in that location on this picture, that's been cut. And then the answer is really to try and do a surgery to repair that nerve and ultimately hope that the signal then travels back through that injured segment. Nerves often take about 1 inch to grow per month. And so if the injury happened there in the hand, you could count that it may take 3 to 4 months at a minimum before you'll even begin to get sensation at the fingertip, even with repairing it. Now I mentioned tendons. This is a schematic. Hopefully you are all okay in seeing some of the inner anatomy of our arms, but nerves will connect a muscle to a bone. And these are often also lacerated. And I have a picture following here where, once again, the avocado where the slipped knife cut the tendons that supply the ring finger. And normally there is a resting tension on our tendons where you can see the index, middle, and small finger. They're just resting in position and they're sitting there in a slight curved posture. Well, just if the patient walks in with their hand looking like this, I know for sure that they've cut the 2 tendons that are like ropes that attach at the tip of the finger. And when the muscle pulls on those ropes, it will curve your finger down and help you make a fist. In this example, that small little cut caused a pretty substantial injury, and the recovery from this is about 3 months of recovery time from a tendon repair. So arteries and veins, this can even cause a threat to the limb, and these are often involved in traumatic injuries. And obviously this requires a very emergent repair. We are blessed with having what we call a lot of collateral ligament blood flow in our hand. So sometimes if something is cut, there is a secondary artery that can provide blood to the injured part that doesn't jeopardize the vascularity of that digit or that part of the hand. So some do have critical arterial injuries, and these are the types of things that are often then treated emergently after going through the emergency room straight to the operating room. So I mentioned if you have someone with an arterial bleed where the artery was cut, you should obviously apply direct pressure. We want to minimize blood loss so that that the patient doesn't have other consequences. We often see also traumatic injuries that are open fractures where the bone is actually coming out of the skin, and that's another example of where the patient would need to go to the operating room immediately, along with a blood vessel injury like an arterium. So kind of switching gears from the more, substantial type of traumas, I do want to mention finger crush injuries. It's likely that everybody on the panel has at some point in their life had a crush injury to their fingertip, and these can often be quite painful. I do recommend getting it looked at. Usually an x-ray is necessary because you'll see a fracture of the last bone in the finger, and sometimes that's displaced and it needs actually a pin or some form of surgery to realign it. You also see blood collected below the nail plate on the left side. That we call that a subungual hematoma. Once that is about 75 to even 100% of the surface area under the nail plate, we know that there was a laceration that occurred to the actual nail bed. And in those circumstances, we should take that nail off and repair the nail bed. And you could see that on the right side. These sometimes take many weeks for healing and can be a bit sensitive and even have some cold insensitivity where exposure to really cold weather will cause some pain for quite some time. But generally these will heal over time and really have not much consequence. But you should have that looked at. Here's another example of a tip injury. This might have been with a bandsaw. And we as hand surgeons look at the orientation of the injury. You can see this is on sort of the pinky side of the middle and the ring finger where there is soft tissue loss. And as I mentioned, it's really important to look at how are the injuries oriented. The one way on the right side has a substantial amount of soft tissue loss. And in those circumstances, we can do more sophisticated procedures where we might take a skin graft or even an island graft, we call them, with a blood flow to it to cover the tip of the finger so that we maintain the length of the finger and maximize the sensation function after the injury. So there are this I just mentioned because it does go into play what we would do based on the orientation of the injury. So I mentioned various treatment options for tip injuries like this. Primary closure means we just can suture it closed and it will heal. Other times we need to do an amputation where we actually have to shorten the finger. If, for instance, there was such crush injury to the soft tissue on the amputated part that really we couldn't either do a replant or saving the tip of the finger is not an option. Sometimes we can just do wound dressing changes and the skin will heal nicely, and over the long term, this is really the technique that most people try to do so that it preserves the best sensation on the tissue that is left on a fingertip injury. Skin grafts and flaps, those are more sophisticated options available to the hand surgeon. Now, again, this talk, I know we're switching gears quite a bit, but we want to hit the heavy hitters, and carpal tunnel syndrome certainly is at the top of the list, one of the most common things I see. And I'll just tell you, the patients will describe the classic symptoms are having numbness at night where it wakes you and you need to shake out your hand at the side of the bed to try to help restore sensation. Sometimes with vigorous squeezing and gripping, you develop numbness. Even while driving, that's a common complaint that from prolonged gripping the steering wheel, that patients will have numbness. Often it's worse with vibration, using tools that have vibration. And remember, I told you about the nerve. Well, this picture on the left is kind of like a bread slice or a cut through the wrist, and the green arrow is pointing at the nerve. And the other kind of circular structures you see here are the tendons, and they are in a very set, tight space through the bottom part of your wrist on the palmar side. And if there's any swelling around there, the nerve will take the brunt of that swelling, and therefore the sensation fibers will be disrupted that go to the thumb, index, middle, and half of your ring finger. And you may have numbness and tingling in those fingers when you have carpal tunnel syndrome due to pressure on that nerve. So some of the tests we do, and maybe you can do even at home, is you can tap right in the center part of your wrist with your middle finger. And if you get an electric shock-like sensation into those fingertips, That's called a positive Tinel sign. You can also bend your wrists at 90 degrees like you see on the bottom there. And if after say 20 to 30 seconds you begin to have numbness and tingling, then that also is a positive sign for carpal tunnel syndrome. The picture on the right, it's a little hard to appreciate, but that's showing the thumb musculature. And if the padding on your thumb in this area becomes scalloped or there is no further muscle tissue here, then you know you've had long-standing carpal tunnel syndrome. And patients with that problem, unfortunately, sort of the horse is out of the barn and we can't really change and put new muscle there. So you really don't want to let this go for too long because it may have a consequence in the function of your hand. So the things we could do for carpal tunnel syndrome, we typically try to do conservative treatment. We'll try splints or wrist braces. Definitely wear those at night. That helps prevent wrist bending at night and therefore no added pressure to the nerve. We can also try cortisone injections. Sometimes your doctor might order a nerve test. It's called an EMG NCV study, and that will give us objective data and tell us the level of severity that may exist on the pressure on that nerve in your wrist. And if the nerve testing shows that it is severe, then really the options like splints and injections are not shown to provide any kind of benefit. And that's where we then would likely resort to doing a surgery where the tight covering that is over that nerve is released. And there are various techniques out there by doctors, but the number one goal in every circumstance is to release this tight ligament that is over your nerve and thereby minimize the pressure that's on that nerve. And hopefully it restores better sensation in the fingertips. So going down our list of heavy hitters, that was carpal tunnel syndrome. Now we're going to talk about lumps and bumps. I see many patients that have one of these, we call it a mucus cyst, and it originates, the picture on the left is the last joint in the fingertip, and you can see this tiny cyst that can form. And visually it looks like the picture on the right, and that bump will cause pressure on the cells that create the nerve plate, and patients often develop ridges and kind of a valley in their nerve, or excuse me, their nail plate because of the pressure on those cells. And sometimes we can either do cortisone shots into that cyst, but that of course doesn't take the cyst away. It just kind of flattens the balloon. The way to get rid of the balloon is to make a skin incision and elevate that flap of skin and take the balloon out so that it minimizes this bump from recurring. Now, other bumps that occur, very common problem is a ganglion cyst. Usually they're on the top part of the wrist here, but about 20% they're on the bottom part of the wrist. And I tell patients this is like a balloon that has formed from deep inside the wrist joint, and it fills with fluid. And there are options to take care of this. You can either let it be because it's a benign problem, but oftentimes the size of this ganglion will cause irritation of the surrounding tissue and cause pain, particularly if they're on the top part of the wrist, doing things like push-ups and opening a large heavy door with your wrist extended. That can cause some pain over that area of the ganglion. So I often offer aspiration or trying to draw that fluid out of the balloon. Unfortunately, again, that just flattens the balloon. The balloon can fill up, I'll tell patients, can fill up on your way to the car in the parking lot, unfortunately. So, but 50% of the time, that's successful and the balloon doesn't fill back up. So the other alternative then is to do a surgery where we can carefully dissect that balloon and take it out. So moving on to some other major problems that I see is arthritis. And let's focus on hand arthritis for a moment. You see in these pictures, this patient unfortunately has developed, we call it angular deformity, where it's angled off to the side. Sometimes you can get a rotational deformity where the fingertip can start curling one way or another. And what the reason for that is because the joint has horrible arthritis in it and is abnormally wearing. And if it abnormally wears down on one side, the finger's going to point in that to that direction. So the nomenclature is the last joint is called the DIP joint. The next joint up the finger is the PIP joint. And then the one that's very commonly involved in arthritis is the thumb CMC joint at the base of the hand. So when we're out at the tip of the finger, here's an example of an option for people that have really horrible arthritis there and pain. What we can do is take out any of the bone spurs. Sometimes we'll even see those small mucus cysts forming in the setting of arthritis. And the way to deal with this is to fuse that. This patient will never be able to move the fingertip again, but this is a good solution because it really helps eliminate pain associated with the arthritis. When we move up the finger to the next joint, now we have a more viable option of actually replacing the joint surgically. Now we could try first cortisone injections, resting, splinting, and anti-inflammatory medicine. But if those things fail, just know that there are options such as this little kind of silicone implant that we can put in there. And the concept is similar to like a knee replacement. You're essentially cutting off the ends of both bones at that joint and then putting in this little silicone implant that has a hinge on it, and it still allows the patient to move the finger and ideally resolve the pain that was associated with moving that joint. So moving on down the hand to the thumb. This is a very common problem. I see a number of patients nearly every single day with this. Unfortunately, the arthritis in this location is known to develop in 1 of 4 women and a little less frequently in men. It's the most common site in the upper extremity for arthritis. And despite being present and patients having arthritis there, I will say that not everyone has symptoms. So sometimes a patient will see me and they had an injury and I'll take an x-ray and they have a fracture elsewhere in their hand. But I do notice that on that x-ray, they have horrible advanced arthritis at the base of the thumb. And I'll ask, is this a problem for you? And there are many patients that, despite the presence of what we see on the x-ray, they have no pain. So really the only time for us as doctors and surgeons treating this problem is really just for pain management. It's not for cosmetic reasons usually. It's more for just pain, and if this is interfering in your life, the things that you like to do, if you can't play pickleball or you can't play tennis because of the pain, or even crochet or whatever it might be, there are solutions that can really help. So this particular joint is unique in that it is like a saddle, and like a person sitting on the saddle, and it allows for all of these types of degrees of motion. It's very sophisticated, and it relies on a ligament restraint. What happens is over time, as we get older, that ligament sort of, I guess a fancy word is attenuates, or it just kind of becomes less stable. And then the bones begin to wear more abnormally, and one can develop arthritis in that spot. So if I move on, the typical history that I see in a patient with this problem is somebody who's maybe in the 50 to 70-year-old range, female, but I definitely see many males with that same problem. Oftentimes people that have really used their hands, forcefully over the course of their careers. And they describe having an insidious onset of pain at the base of the thumb. There is pain with writing, grabbing doorknobs and twisting, opening large jars. That requires you to really open up your thumb and squeeze, and that will really often be a hallmark sign of pain and arthritis at the base of the thumb. The pain is usually a diffuse sort of aching pain all around the base area of the thumb. And here again is a picture of where that location is. So We have various options, in treating patients with this, and I can go on to some of those options here. Non-surgical management, again, involves using anti-inflammatory medicine, avoiding those activities that cause problems. This particular splint is called a comfort cool splint, and many patients swear by it. It helps support that joint so you're not moving it as much. And if you're not moving it as much, it should be less painful to you. If those things fail, we can try a cortisone shot, and many times that's quite effective in helping reduce or even eliminate pain. Ultimately, there are surgeries that can be done, and I will say there are many variations that have been described, but the technique for addressing this has been described over 50 years ago, and it comes down to simply, you can see in this left-hand diagram of this x-ray, this red bone is called the trapezium. And the surgery that has been designed for this involves taking this little bone out of your wrist and then taking a tendon from your forearm and rolling it up and putting it in there as a cushion. And so the bone comes out, the cushion goes in, and you no longer have the two bones now rubbing on one another, which was the source of pain. You can see on the x-ray on the right that there is a void where that bone was. And that's after having had the surgery, and it's a great solution for this problem. It does take some time to heal, but ultimately patients are very happy with having done this. Now moving on to wrist arthritis. You can see on this x-ray, I know you're not maybe accustomed to seeing x-rays, but the little bones of the wrist there in the center, there is essentially no space between those bones and the two bones of the forearm. The bone on the right, on the left is the radius, on the right is the ulna, and there is really no space between the little bones and the radius. And when that happens, that once again is similar to hip or knee arthritis. The good cartilage has worn off, and now you're left with the remaining bones touching one another. And that's often a source of pain. It can also be due to failed prior surgeries. I have some examples here. I won't go into them in detail, but sometimes as hand surgeons, we have to address a fracture or injury around the wrist joint or a ligament injury. And over time, patients can still develop a post-traumatic arthritis that involves their wrist joint that we still might need to intervene for that problem. So sometimes patients don't recall a specific injury. Many times wrist arthritis will develop because of a fracture that had occurred to one of the small bones in the wrist. I do see a lot of younger kids, oftentimes they think they've sprained their wrist, or younger in the sense that maybe they're in their 30s and they were skateboarders, and they recall a number of injuries after falling where they had bruising and swelling, but they just simply never had anything done about it or any x-rays. And they come to my office and I can see that potentially they've had an old fracture and now they've developed wrist arthritis because that was not treated. And then there are options, that we have to pursue that way to maximize, the current situation. So one of the things, Karen had actually even mentioned this, I am one of the few surgeons in the Chicagoland area that does do total wrist replacements. In the past, years ago, the implants were not as sophisticated as they are now. And so there were some problems with implantation of the wrist replacement. And I again kind of refer to what a knee replacement looks like. We're doing the same concept at the wrist. We're using metal implants along with, it's called polyethylene. And those surfaces are now what creates the new wrist joint. And there's been a lot of research that is done. The motion it's very sophisticated in how these implants are now fashioned so that it is an elliptical contact where you can even have what we call the dart thrower's motion, where you can circumduct your wrist in a circle. And that's a very sophisticated motion compared to, for instance, like the knee, which is essentially just full straight on in one plane. The wrist has to function in a number of different arcs of motion. And so now the implants that have been fashioned are much more sophisticated. And this is really a great option, I believe, in treating patients that have bad wrist arthritis. You can see the x-rays on the left showing the implant. And on the right, here's an example of the patient's motion without pain. And prior to surgery, this patient would have next to no motion and have exquisite pain in function of their wrist. Here's a patient also that had this wrist replacement done. I'll try to play the video. He's playing tennis and not having pain. Here's what his wrist motion is like. You can see he's probably been in the garden a bit too with the dirt in his hand. So just to reinforce that, there are options for wrist arthritis that I think traditionally have been overlooked by the hand surgeon community, and there are good options. So moving on to some other problems affecting the wrist, we call this de Quervain's disease or tendinitis. I often see this in patients who do repetitive use where they're moving their wrists back and forth, either at their job or even new moms who will grab their babies under the armpit and do a lot of lifting and moving their wrists. And it can cause inflammation of the tendons in this hash mark area on the wrist. It can often be exquisitely painful. And this is a test that you can do. Tuck your thumb in your palm and just lightly wrap your fingers around and then deviate your wrist off to the pinky side. And when I do this in the office, I try not to be too forceful, but some patients, you'll jump out of the chair if that's the source of your pain, because those tendons get stretched in this tight compartment and it can be exquisitely painful. There are really good options to treat this. A cortisone injection is very effective at making this problem go away. And in those patients where it still lingers, we can do a surgery that will really solve the problem forever. So trigger finger, also a really common tendinitis problem. We're shifting gears here now to in the hand, in the palm of the hand, we see patients that have locking and clicking of their fingers. Often it's worse in the morning and the finger is stuck down in their palm, and to straighten it requires forcefully using their other hand, and it can be very painful. So this is called trigger finger. It can affect any of the digits in the hand, and there are, once again, good solutions. You see where the green arrow is in this dissection, there's a very tight covering over the tendon, which is like a rope. This rope slides back and forth about 5 centimeters when you make a fist and straighten your finger. So the tendon can develop almost like a knot on a rope, and it gets hung up under this tight covering. So the injection can reduce the size of the knot, or we can simply release this tight covering in surgery, and that will solve the problem forever. So thanks for sticking with me. I just have a couple additional conditions to review with you, and then I'm happy to answer any more questions. So we're moving up the arm to the elbow, and it's quite likely that some of the people on the panel have experienced this. It's a very common problem. The sophisticated name is lateral epicondylitis or tennis elbow. This is tenderness over the outer part of your elbow on the bone, and this is where the muscles that control your forearm and your wrist, when you make a forceful grip, that muscle all comes together and inserts in a common tendon in that little hash mark on the outer part of your elbow. And once you have it, it's very difficult to get rid of it because nearly everything we do involves us squeezing and gripping. So once you have it, even lifting your coffee cup or a water bottle when you squeeze and grip will be associated with pain. And this pain can radiate up your arm or even down into your wrist. So we typically will try conservative things. Again, injections, therapy can be quite helpful for this. Wearing a wrist brace for this problem, it seems weird. Why a wrist brace for the elbow? But as I mentioned, the forceful grip position uses the tendon up at your elbow, and that's the culprit in this problem. So if you slow down the forceful gripping by wearing a wrist brace, you can offload the elbow. Surgery can be done for this problem as well. It's usually a last resort, and there are various techniques in addressing it, but ultimately the goal is to kind of clean out the area where that tendon is so inflamed and to stimulate healthy healing in that tissue bed. So our final topic tonight is cubital tunnel syndrome. This is, I guess, the close family member to carpal tunnel syndrome. This is a picture on the inner part of the elbow, and the hashed area is the bone that's on the inner part of your elbow, and the two lines represent the ulnar nerve. Some people call it the funny bone. If you hit your elbow hard on a hard object, you may get that electric shock sensation into your ring and your small finger. That is the ulnar nerve. And there can also be just some added pressure on the nerve in that area due to swelling and thickening of the tissue. And that can cause numbness and tingling into your small finger and your ring finger. So sleeping position is often a culprit. If you sleep with your elbows completely bent, or if you're on your phone for a long time, it's a common problem that I hear patients say that if they're laying in bed and their arm is resting right on that area and they're also on their phone, they begin to get numbness and tingling. And so the solution there is trying to keep your elbow more straight. You can even, wrap a towel around your elbow, or there are braces that can be worn that help keep your elbow straight and hopefully alleviate the problem of the numbness and tingling. The couple of the exam techniques that we do is a Tunnel sign, or remember I mentioned tapping over the nerve. We do that at the wrist for carpal tunnel syndrome, but also over the elbow for cubital tunnel syndrome. If it causes an electric shock-like sensation downstream, then you have cubital tunnel syndrome. Also, you can do what's called the elbow flexion test. Just bend your elbows up at maximum and let it sit there for 20 to 30 seconds. And if you begin to get numbness and tingling in your fingers, that's a positive test. We can also order a nerve test for this problem, similar to carpal tunnel syndrome. And the doctor that does this type of testing can tell us if there's pressure on that nerve at your elbow. Conservative techniques are to wear a nighttime splint to keep the elbow straight. Thereby, that nerve is not being stretched, because when you bend your elbow all the way, the nerve is stretched behind that small bone, and it has a poor blood supply at that time when it's fully stretched, and you'll get symptoms. So wearing a nighttime splint to keep the elbow straight is a simple thing you can try. And then ultimately, if it's not successful and these symptoms really interfere in your life, then we can release that tight covering on the nerve at the elbow. And sometimes we even have to take that nerve and put it in front of that small bone on the inner part of your elbow. It's one of the techniques that your hand surgeon would discuss with you. But it's a good option if you're having chronic problems with numbness and tingling. This cubital tunnel syndrome can also cause weakness in your hand with squeezing and gripping. And if you start to feel clumsy in using your hand, this can sometimes be the culprit. So you definitely should have that checked. So that's the conclusion. I really appreciate your attention. Hopefully some of these topics have resonated with you or and generated some questions. And once again, I appreciate your time.
Awesome. Thank you very much, Dr. Hoepfner. Yes, you did generate some questions. And so
Okay.
we'll just go right at them.
Okay.
The first one that came through regarding arthritis in the thumb is, does massage therapy help for arthritis at the base of the thumb?
So massage therapy, I think it's a wonderful thing. I think it's worthwhile trying, but usually thumb arthritis is a structural problem. So if you have a lot of pain associated with the joint destruction that occurs with the arthritis, then doing the massage therapy is potentially only going to aggravate the area if they push hard in an area that is sensitive. So this is one problem where you can try it, but it's not known to be a real lasting solution.
Got it, because the massage would help the muscles, but it's really the joint that is the issue.
Correct.
Got it. Okay. And what causes finger arthritis? You know, I know like people get arthritis in their knees from running when they're younger or playing football or something like that. But do you not do they know what causes the types of arthritis that you were showing in the fingers?
Well, arthritis in the hand is very common, and you're right. People run and they use their knees, but we use our hands all day, and there is likely a genetic predisposition. I will see many people say, "Oh, my mom or my dad, their hands looked
Okay.
horrible. Had all these things, later in life." And so I think there certainly is some genetic relationship, but those small joints of our hand, the ones that I had pointed out to you on the screen, they bear a tremendous force when you're pinching and grasping things, and
Okay.
especially the base of your thumb. If you hold a stack of plates, you are putting tremendous pressure at that joint in your thumb. So just activities of life can cause those joints to wear out and become arthritic, unfortunately.
Okay, that actually makes a lot of sense, and that helps me to understand better. So hopefully other people do as well. All righty, so let's see. Someone had a cortisone shot that helped for arthritis of their thumb for a while, and it's starting to wear off. How do they know when it's time for surgery?
So that's a great question. And hopefully, your doctor will share with you that, you know, surgery for this is an elective thing. So, we don't want to do too many cortisone shots because that can be detrimental to the soft tissue.
Mhm.
Uh, but if the pain is not really interfering in the things that you want to do in your life or the things you enjoy doing or your work, um, then you can let it be. And so it really should never be, the doctor's decision for you. They should, in consultation with you, let you know what are the options, and know that there are good solutions if the pain is so bad that it really is beginning to interfere in your life. And that's really the tipping point.
Great, that makes sense. Thank you very much. Okay, someone says that after knitting for a couple of hours, their hands don't work properly. They drop things like that. Are there stretches or exercises that would help?
That the reason for that problem with dropping things. So I think it needs to be investigated because it could be truthfully a number of different things.
Got it.
And it could be carpal tunnel syndrome, which I just shared is a nerve problem.
Right.
It could be arthritis. Um, so or it could be a tendonitis problem. So I think that would warrant being evaluated just so that this person is shepherded in the right direction and what might be a good solution for that problem.
Great, thank you. That's a great suggestion. Someone asks, are double jointed or hyperflexible joints like fingers or elbows more susceptible to arthritis?
That's also great questions coming through. Thank you.
I told you we have a very sophisticated audience.
Yeah, they are. Wow. Those joints are a little bit more prone to developing arthritis because there's more shearing forces that's occurring over those surfaces. And with time, if there's a lot of stress put on those joints, they unfortunately could develop arthritis earlier on.
Great. Okay, how about this? You recommended a wrist brace for tennis elbow. How about one of those bands that fits closer to the elbow, someone asked?
Okay, that is something that patients frequently use. I will tell you, the studies have shown that it really doesn't make a difference one way or another. I think I personally feel like it's okay for someone to wear those. It doesn't cause harm. I just would caution, don't put it on too tight because while I said it doesn't cause harm, if you put it on too tight, there is a nerve that it could aggravate if you put it on too tight. But if it seems to help you and you wear it, you try it and it seems to help you, then that's fine. I'm all for that.
Great, thank you. Okay, if someone has arthritic fingers, have you heard that acupuncture can help?
I have heard that acupuncture can help a lot of different problems. I've not heard such success with arthritis, but most definitely for things like I've described with the tennis elbow problem. Tendinitis issues often are very responsive to acupuncture.
Got it.
And I wouldn't be against, someone trying acupuncture. I personally don't practice it, but I feel like it also wouldn't be, harmful to the patient. So it'd be worthwhile trying.
Great. Okay. And someone asks, does cubital syndrome cause hands to fall asleep?
Yes,
Okay.
it can cause the hand to fall asleep because of the numbness and the tingling in the pinky side.
Got it.
But yeah, so I guess a short answer, yes.
Okay, great. Thank you. All right. Okay. They're coming in so fast now. They're just moving through, and then I find one, and it flips through, and I get a different one. Okay. Does a hard, small bump in the palm of my hand, just below the base of the index finger, which is a trigger finger for this person, that hurts when pressed? But is it something to be concerned about? So a small, hard bump at the palm of their hand. So that almost sounds like that's the thing you were showing
Yes.
for the trigger finger.
Well, there are two things that this could be. One, it could be a small ganglion cyst, and in that location, we call it a retinacular cyst. And they sometimes come from the tendon sheath in that area that's associated with trigger finger. So I can't tell without examining or maybe even getting a study, but just to know that it could be that. Or there's another condition called Dupuytren's disease, which maybe some people have seen. There are some companies advertising treatment for this problem in the lay press, but Dupuytren's disease is simply a formation of nodules of scar that can exist in the palm of our hands or even in the soles of your feet. And it's a growth, it's not cancer, but your doctor needs to look at that to determine what is this bump. And as I say, it is likely one of those two things.
Great. So it is something to be concerned about and to get checked out.
It should be checked out.
Great, thank you. And I did see a question here about Dupuytren's contracture. They said, what about treatment for it? And I know you talked very briefly about it. And I probably was reading questions. Did you explain what to do about it?
So I didn't, but that could be an entire talk.
Got it. So we'll mark that down for next time.
Yeah, well, I can just say briefly, I mean, yes, there are definitely things that can be done for Dupuytren's disease. In a nutshell, we typically try not to do anything if you're able to keep your fingers straight. What will happen in Dupuytren's disease is that scar tissue gets so thick on the palm side that it starts to pull your finger down.
Okay.
And if the nodules are there, but you can still keep your finger straight, then we typically don't do anything about it.
Got it.
And then if it's more advanced, there are either procedures or surgery that can address it.
Okay. Okay, great. All righty. Are there things to do to preventatively avoid arthritis and arthritis issues?
Well, early in the process, there are health food supplements such as glucosamine that you can purchase, and they provide the building blocks of cartilage. And so I will often tell patients, you can try that. You can try turmeric, which is also a health food supplement. And as long as you're not taking excessive doses, these are simple, basic things that can be tried to help address what is happening over time of the wearing away of that cartilage.
Great, thank you very much. That's good to know. Someone is asking, what is the recuperation time for wrist replacement surgery? I know you said you do that.
Yes, that's a great question. So that surgery is done actually outpatient, and it takes about an hour and a half, and patients go home that day. They obviously have a bandage on their hand, and when they see us about 10 days after surgery, we transition to a removable cast that they wear for about 4 weeks. And all along, they're encouraged, truthfully, a couple of days after surgery, they could be driving a car. They won't be moving their wrist, but their fingers will be moving, and I want them to. And then by about 6 weeks, we have them finish with the casting and begin therapy to work on their motion and their strength.
Great, great, thank you. All right. Someone mentions that they get trigger finger just once in a while. Is there something they can do to prevent it from getting worse, like exercises or ice or heat?
Icing and heating isn't really shown to make any difference. One thing they could try is you could buy a simple splint at Walgreens or CVS that keeps your finger straight at night. Because oftentimes at night we curl up our fingers and then the tendon gets stuck under that tight covering. So if you keep the finger straight at night, it might help prevent this from becoming worse. And then also, if the patient can tolerate it, that there are no medical contraindications to taking a medicine like Advil or Motrin as an anti-inflammatory, that also is something basic that can be used.
Great, thank you. Excellent. All righty. This person asks, what is the typical prognosis for medial epicondylitis? And will it resolve on its own, or is intervention required? And I know you mentioned it can last a while. If PT is recommended, would this be administered by a hand PT specialist or a general physical therapist?
So medial epicondylitis is golfer's elbow.
Oh, that's right. Yeah, that's right.
So I spoke about tennis elbow, but I will tell you they're essentially identical. They're both hard to get rid of. And we know when we say the natural history of a problem, that means what will happen over time. What's the typical course for this problem? And our information says that this usually kind of works itself out and goes away, but it may take even 6 to 9 months if you did nothing. But most people don't want to live with that level of pain. So that's where the therapy can help. Wearing a wrist brace can help. The cortisone injections for really more severe problems, and even surgery in severe problems. As far as the question on a PT versus what we call OTs, I lean towards sending patients to OTs because they only treat the hand and arm. And so physical therapists, while I'm sure many can very effectively treat this problem, they also treat, neck problems, hip problems, knee problems, shoulder problems, back problems, and the arm. So, I feel it's helpful to go to someone who's seeing this on a daily basis.
Got it. That makes a lot of sense. Thank you. Okay, 7:58. I'm watching the clock for you.
Okay.
This person says, when do I abandon my rheumatoid arthritis treatment for my hand, thumb, and wrist arthritis and see a surgeon? The RA meds over 7 years just haven't worked. Any suggestions for them?
Yeah, I think I highly recommend having that evaluated. There's no obligation, but maybe to get an assessment and see what might be possible. Oftentimes with rheumatoid patients, there are simple, isolated procedures or splints or things that can really substantially change and help their function. And so I would suggest having it looked at sooner rather than later, because sometimes as it progresses and gets more and more severe, your options of treating it become less and less, and they become less likely to give you a good functional outcome.
That is excellent advice. And I just want to let you know, I keep getting questions that say, excellent talk, really informative. Thank you so much. So I want to make sure you know that as well, Dr. Hoepfner. For those of you who had more personal questions, please visit Dr. Hoepfner. His information is here at his office locations in Grays Lake, Lake Bluff, and Libertyville. Again, Dr. Hoepfner, thank you so much. It is 8 p.m. Thank you, everyone, for joining us tonight. Thank you for all the wonderful questions. I'm sorry we didn't get to all of them, but please do go see Dr. Hoepfner. He seems like a really great guy, too.
Thanks so much, everybody.
All right, have a great evening, everybody. Thanks again, Dr. Hoepfner.
Thanks, Karen.
You bet.